my dear colleagues and friends, and I'll be talking about pregnancy and malnutrition, both about the over malnutrition and under malnutrition. Next. See, what is the definition of malnutrition? Is according to WHO, it is a condition caused by deficiencies, excesses, or imbalances in a person's intake of energy and or nutrients. And it includes 3 dimensions: overnutrition, which includes overweight and obesity, and then undernutrition, which also includes stunting, wasting, and underweight, and lack of essential micronutrients in diets like iron, calcium, etc. So what is interesting is that it results in a measurable adverse effect on the body composition, function, and clinical outcomes in both types of the malnutrition. And it is possible to be both overweight and micronutrient deficient, which is very common in our younger generation because of the type of foods they eat. And in pregnancy, they are anemic. See, now because I am a public health person, I thought I will share some interesting facts about the obesity pandemic globally. And there was a Lancet study on global health burden of obesity. Can you hear? Hello? So can
yes,
you hear?
ma'am.
Okay. So there
yes,
is.
We can hear you.
Okay, so there is a Lancet study on global health burden of obesity published in 2022. I've written 21 by mistake, which made the following points. That is a more than 3% prevalence among children and teens, which is an increase of over 3 percentage points since 1990. Then female obesity is increasing sharply. So women had a 9.8% prevalence, an increase of 8.6 percentage points since 1990. And India ranks 182 among 197 countries for the prevalence of obesity in women. So we are really down in the dumps. Now 8 countries like China, India, the USA, Brazil, Russia, Mexico, Indonesia, and Egypt, they have more than half of the global population with overweight and obesity. Now the highest numbers were observed in China, India, and the USA. Next. Now this is the projected trend for obesity in India. The study shows that 44 million women and 26 million men aged above 20 in India were found to be obese in 2022, compared to 2.4 million and 1.1 million in 1990. So there's an enormous increase. And India is certainly facing an epidemic in the younger population. So 12.5 million children, of which there are more boys and less girls, aged between 5 and 19, were grossly overweight in 2022. So, now gross obesity is also coming into the picture. And nearly 60% of adults are expected to have overweight and obesity by 2050. And among the females, it is expected to increase by nearly 60% with the associated burden risks for pregnancy and conception. In South Asia, adult obesity is closely linked to childhood obesity. So if one enters obesity in childhood, it is more likely to continue on to the younger age in pregnancy as well as in the older ages. And with the global prevalence of obesity in children and adolescents, which has increased by 244% in the past 30 years. And there is a forecasted increase of 121% in the next 30 years. So trends in adult obesity are unlikely to abate. So what we have to do is wake up, call to act now. Next. Now, malnutrition is a double burden for both. It means that both over and undernutrition is bad. And both of them can lead to early onset of a variety of complications, including type 2 diabetes, CVDs, NCDs, like arthritis, and certain cancers as well. These complications impede the progress in population life expectancy and healthy life expectancy. And childhood undernutrition triggers physiological adaptations that stimulate energy accumulation in adipose tissue later in life, leading to obesity in adulthood. This pattern of life course exposure to the double burden of malnutrition triggers a metabolic capacity load mismatch. And this aggravates the risk of NCDs. And there are always also increased susceptibility to infections. Now, interesting fact is that, can we go back? The largest annual growth in ultra-processed food and beverages sales per capita was seen in Cameroon, India, and Vietnam. So here is the culprit, that what we eat. Next, please. And now I'm going to make it very short. Maternal complications in obesity is gestational diabetes, high BP, preeclampsia, more cesarean rates, venous thromboembolism, which is actually underestimated in India, and it is very common in the grossly obese. I think we should pay more attention to prevention strategies for preventing VTE, and it worsens sleep apnea. And the other big thing is the macrosomia, which can affect both the mother as well as the child adversely. For the mother, it can result in... Hello?
Yes, ma'am, continue.
Maternal complications, it can lead to... Screen went off.
मैम थोड़ा नेट प्रॉब्लम आ रही है आपकी साइड से.
मैं बोलते जाऊं मेरी तरफ से?
अब आ रहा है, बोलो.
हाँ, अब आ गया. So macrosomia can lead to protracted or delayed in the conduct of labor and uterine rupture, genital tract lacerations due to difficult deliveries, and or postpartum hemorrhage. And how it affects neonates is that the large for dead babies have an increased risk of shoulder dystocia, clavicular fractures, brachial plexus injuries, and nerve palsies. Next. Next one.
Yeah, we have done.
Other complications are stillbirth, and because obesity is associated with an increased risk of stillbirth, and preterm birth predominantly due to preeclampsia and macrosomia, which can lead to medically indicated preterm birth. So this puts the baby at risk for short and long-term health problems. And also there is an increased risk of the childhood obesity, which continues on to the generations and to come. And miscarriage is also more common, especially if they have high blood sugar levels during the first trimester. Increased chance of infections in the urinary tract and other infections during pregnancy. That also includes vaginal infections. And postpartum hemorrhage is an important complication because of the risks of prolonged labor, and because we have to do more cesareans or do more vacuum and forceps deliveries because of the big babies. The next one. Now, anesthesia risks are also much increased in obesity. There is an increased risk of aspiration, epidural and spinal failure, difficult endotracheal intubation, post-op hypoxia, and atelectasis. So whenever we should be very careful about these anesthesia complications. We may miss them and land up in trouble when you do handle these cases. Then increased fetal and neonatal complications. The adverse outcomes associated with maternal obesity, like increased insulin resistance, inflammation, and oxidative stress associated with obesity, can take part in early placental and fetal dysfunction. Several fold increase is seen in congenital anomalies, and even if you give them adequate folic acid, so they can still have it. So it is important to counsel these ladies during the pregnancy. And neonates that are large for dates have an increased risk of shoulder dystocia, clavicular fractures, brachial plexus injuries, and nerve palsies. So all of these complications, we should counsel the obese patients in advance to save ourselves from any type of, legal cases later on if something wrong happens. Then we come to prenatal and antenatal care in the obese. Calculate the BMI of every woman who comes to your antenatal clinics and see if they get into this obese or cross obesity or the other group. And then you counsel patients about limitations of identifying structural anomalies with ultrasound in obese patients, because the ultrasound has limited depth and we can miss a lot of anomalies. Then do the glucose intolerance and assess for in these patients who have a BMI of more than 30, or if they have a history of a gastrotomy, or if they have impaired glucose metabolism, and recommend early glucose screening for those with risk factors. And if the BMI is more than 40, then consider initiating weekly surveillance at 34 weeks. And for BMI 30 to 39, the surveillance should start at 36 weeks for complications. Next one. Intrapartum care, you have to monitor the labor carefully. The labor pattern may be prolonged, but cesarean should be avoided because of the increased complications seen. The other thing is like a cesarean incision, where to give it if the patient is so obese. There was one case in Safdarjung Hospital long back, the huge lady. So what we had to do was we had to join 2 operation tables, and then my friend who was handling that patient, she had to climb up on the table to give the incision because that patient was so huge. So you can imagine the number of obese patients which are going to come. So maybe you can opt to buy bigger operation tables to be prepared for this epidemic. And if there is a large panniculus, which is like an overhanging abdominal wall, then one can consider a supraumbilical incision. Then antibiotics should not be given just like, we are used to giving at a certain dose, but it should be calculated according to the BMI. And it's important to do a very thorough cleansing prior to a cesarean, or even if you're doing a forceps or a vacuum. So thorough vaginal cleansing is very important. Next one. Then postpartum care. Now venous thromboembolism, mechanical prophylaxis, you put the pumps on the patient's feet. So these are non-invasive in nature, and they can help prevent the VTE prophylaxis. You should do it for every case of a cesarean, especially if the BMI is more than 40, for vaginal birth as well as for cesarean. And for class 3 obesity, you can consider using low molecular weight heparin, which is enoxaparin 40 milligram daily. Or you can do a weight-based VTE in class 3 obesity following a cesarean. And the dose is 0.5 milligram per kg every 12 hours, starting 12 hours after the surgery. And one should avoid putting any type of a drain in the wound. And one should continue with the diet plans later on in the post-op period. Next. Now, what are the long-term effects of obesity in pregnancy? All of these women retain more weight postpartum, and it is more strongly associated with weight gain during the first trimester. So the more weight you get in the first trimester, the more likely you will continue to be obese after delivery. And other adverse health outcomes in the offspring, including an increased incidence of metabolic syndrome and obesity in the child. And this can be carried into adulthood, suggesting that fetal overnutrition can affect the life cycle of the baby, and also increased NCDs in later life for these obese women. Next. Undernutrition in pregnancy. Now let us talk a little bit about undernutrition in pregnancy. Globally, maternal malnutrition accounts for 7% of the disease burden and contributes to at least a fifth of the maternal mortality. So 20% of females are dying due to malnutrition, undernutrition rather. And there are higher contribution of poor pregnancy outcomes. So there's more morbidity as well as mortality. Now, undernutrition during pregnancy or maternal undernutrition is defined as a pregnant woman's BMI of less than 18.5 kg per meter square. Or one can measure the upper middle arm conference, which is, if it is less than 23 centimeters, then she is classified as undernourished. And then also the third criteria is hemoglobin. If it is less than 11.5 during the first trimester and less than 10.5 during the second and third trimesters. Then the maternal risks of undernutrition. There's an increased risk of anemia, preeclampsia. So it's more or less similar related complications. But P-sepsis is certainly more in the undernourished. And it can also lead to increased maternal mortality, morbidity, and near miss. Then risks for the fetus is low birth weight, preterm birth, IUGR, and developmental delays after delivery. The malnourished mothers are more likely to have babies with stunting, wasting, and cognitive impairments. So see, for us, I think for your population, all the private practitioners, you will rarely get to see these undernourished and malnourished patients. So when I was in WHO, I had gone to visit these Adivasi women in the tribal areas, and there they feed the women less during pregnancy so that they get smaller babies to avoid the risk of obstructed labor, because they are living in faraway areas. So that was a very interesting finding. And what are the causes of malnutrition? Undernutrition is illiteracy. This is an important factor because in rural areas it is very common. Rural residents, pregnant women who are married before the age of 18, and no antenatal checkups and substance abuse, and they are not participating in the antenatal programs which are run by the government. And other important factors are poverty, intestinal parasitic infections, skipping of meals like fasting, household food insecurity due to poverty, and there is a very poor dietary diversity associated with undernutrition. Now this is very common in India. Next one. Chronic undernutrition in mothers leads to maternal short stature, higher cesarean delivery, CPD, and an increased need for assisted delivery. So I think nowadays we don't see any. I saw once a patient of osteomalacia when I was a house surgeon. Her knees, I could not straighten her knees. She was so much deficient in vitamin D. And I had to put up a board over there. Do not try to open her knees, otherwise her knees will break. So, and nowadays we don't see that much of undernourishment. An undernourished mother is also more likely to give birth to an undernourished child. Usually it will be smaller for the gestational age. And this cycle is perpetuated from one generation to the next. And in infants and children, data shows that approximately half of the deaths in children under 5 years in low and middle income countries are directly or indirectly caused by mothers who are undernourished. Next one. Now let us talk a little bit about micronutrient deficiencies. So there are about 5 or 6 micronutrients deficiencies which are common. And number 1, omega-3 fatty acids. The short form is DHA. It has been the subject of a great deal of research on pregnancy and breastfeeding. And it has been found that it is essential for brain development. And greater baby DHA levels are linked to improved neurological and visual test results. Then coming to calcium. Calcium may guard against pregnancy-related hypertension. such as preeclampsia. So when I was in WHO, calcium was not on the list of the essential drugs. So, I kept pushing the ministry, no, you have to add calcium. And then they added calcium. And then the daily recommended intake of calcium for non-pregnant women is 1000 milligram. And for the pregnant women, it should be 1300 milligram. But consuming more than what is suggested does not enhance breastfeeding or improve pregnancy outcomes or prevent the inevitable bone loss that occurs during pregnancy and maybe during lactation. And the other important point for obese patients is that using skim milk instead of cheddar cheese allows a woman to get the same amount of calcium with half the fat calories. And calcium retention is reduced by cheese and cottage cheese. So paneer khilana is not a very good thing for a high protein diet for the obese. And next one. Then vitamin D. Prenatal vitamin D is essential for healthy bone development in the unborn child. It regulates blood calcium levels by affecting the small intestine absorption of calcium and phosphorus, as well as losses from the bone. And it increases the chance of developing infantile rickets and have detrimental effects on fetal growth and bone formation. So this is important for women who do not receive enough sun exposure throughout the year to consume enough vitamin D in the diet. Now with all of us sitting in air-conditioned rooms the whole time, we rarely get exposed to any sunlight, to cover up the vitamin D needs. So it's important that we focus on fulfilling the vitamin D needs. Then iron. Everybody knows about iron. Iron needs of pregnant women are nearly triple and are improbable to meet through only the diet. So you need 8 cups of spinach is equal to 30 milligram of iron. Then consequences of iron deficiency during pregnancy include adverse effects on the cognitive and behavioral development of the expectant child. It leads to preterm birth, low birth weight, and increased perinatal mortality. And eating meals high in iron can also lead to adverse consequences in mothers, such as nausea, vomiting, and diarrhea. And this actually perpetuate the undernutrition. Additionally, it may impede the assimilation of minerals such as copper and zinc. So I had done the iron deficiency is so common in India that when in WHO, I collaborated with PHFI to do a randomized control trial on the benefits of intravenous sucrose iron against oral iron. And this was a multi-state study in 5 medical colleges. But unfortunately, there were too many side effects, so it had to be stopped for ethical reasons. But whatever the results had come, there was no benefit of IV iron sucrose over oral iron. So then the next one is vitamin B12. It is essential for the neurological and blood health of both mother and the baby. The 1.5 milligram per day advice for non-pregnant women is the same for the pregnant women. And for a vegan or a vegetarian diet, usually they are insufficient of vitamin B12. So it is important to give enough supplements of vitamin B12 to meet the nutritional requirements of pregnant women. Next one. Then vitamin A. This is also very important because it affects the eye health, the fetal development, and the immune system. So if the mother is well nourished with vitamin A, it will lead to better fetal development, eye health. But if you give too much vitamin A, it can be teratogenic and it can increase the chance of anomalies. Okay, next one. And the last is the thyroid. So we have to control thyroid TSH at all levels to prevent the mental retardation in the newborn. Thank you.